Hi, my name is Noah Cahan. I'm a PhD student under the supervision of Professor Greenspan of the Biomedical Engineering Department in Tel Aviv University. This research was done in collaboration with the Department of Imaging and Sheba Medical Center. We're all familiar with a variety of applications AI has brought into our lives. Most AI applications in medical imaging focus on a specific task that extracts image content. Some examples include segmentations of organs or classification of pathologies. Currently, attention is shifting to prognostic models, combining clinical, imaging, and biochemical parameters. For example, predicting the chance of survival, prognosis of a disease, or treatment response. In this talk, we will specifically focus on the task of finding predictive models for a 30-day all-cause mortality for patients who were diagnosed with PE from two different data modalities, imaging and clinical data. There are a few challenges when considering this task. Medical data is extremely limited. Annotations need to be done by expert and are therefore expensive. Usually, we have a small number of positive examples, so we deal with imbalanced datasets. And finally, fusion is difficult. Combining multiple modalities is intuitively appealing, but in practice, it is very challenging to leverage them. Pulmonary embolism, or PE, is a life-threatening condition. It is very hard to diagnose because it usually doesn't have any specific symptoms. The untreated mortality rate may approach 30%, but can drop to around 6% with rapid treatment. So there is a clinical importance to identifying PE and specifically its severity. PE is a condition when there is an obstruction by a blood clot somewhere in the lungs. The golden standard for identifying PE is a lung CT with contrast agent called CTPA. Below, you can see examples of PE. They're marked with the red arrows. As you can see, the clot is gray, and it's surrounded by bright color from the contrast agent. PE-related existing works focus on the detection of the clot itself, whereas in our work, we address the task of PE severity assessment, where the identification of the blood clot is not sufficient. The assessment of the patient's early death risk is the most accurate way to assess PE severity. But in common practice, existing tools for PE prognosis include imaging tools, clinical predictive rules, and laboratory markers. We retrieved data for consecutive patients who underwent CTPA between the years 2012 to 2018 in our emergency department and were diagnosed with PE. The different clinical variables we've used are listed on the right. Here is a more elaborate table of our data. As you can see, it is very rich and variable. We have more than 40 laboratory tests, demographics, clinical history, and in and out patient medication, around 300 ICD-9 codes, and more miscellaneous data. For example, we have the time of arrival of the patient, or even we know to which ED wing he arrived at. Our data set includes 363 patients. We've split our data to training and testing by years, and the percentage of positive examples in our data set is only around 11%, making it highly imbalanced. For the workflow of this study, we first collected clinical and imaging data. The data set was labeled from a single binary label of 30-day all-cause mortality variable. We then risk stratified the diagnosed PE from the imaging data and the clinical variable data independently. And lastly, we fused both modalities for a multimodal solution. In order to demonstrate the effect of combining different data modalities, we introduced single classification models to be used as our baseline. For our imaging classification model, we chose SANet, which was developed in our previous work. SANet has a 3D DenseNet 121 baseline with addition of stacked residual attention blocks marked in purple. It is capable of classifying 3D images from a single binary label. We chose it due to its high performance compared to other 3D classification models. For more details, you can refer to the manuscript. For our clinical data, we used two models. Our first EMR classification model uses XGBoost framework, which applies gradient boosting on decision trees. It provides state-of-the-art results in many applications and dominates most of the recent data science competitions. For the second EMR model, we use TabNet by Google. It is a deep learning model that is specifically designed for raw tabular data inputs. It uses sequential attention for feature selection and mimics gradient boosting on decision trees algorithm in a neural network setting. For our multimodality models, we explored a number of different models and approaches for fusing the different data modalities. Our suggested models can be roughly split into early or feature-based, late or decision-based, and intermediate fusion. The first three models, A, B, and C, are late fusion models. In late fusion, we extract the prediction probabilities from the unimodal classifiers and integrate them. These three models differ in their aggregation we use. As you can see here, the squares represent the predicted probabilities from each unimodality. For our next model, we used early fusion, which integrates multiple sources of data before being fed into the model. Data can be either raw or pre-processed. Here we extract image features from SANet, shown as circles, and clinical data embeddings from TabNet, represented by the triangles. Our last model uses intermediate fusion. In intermediate fusion, we concatenated extracted latent space features from both modalities. This fusion strategy is perhaps the most powerful and flexible one because we can collect different features from various levels. The concatenated vector is then passed through a PCA that reduces the vector dimensionality and also enforces a shared representation. Finally, the reduced vector is used as input to an additional TabNet for classification. We compare our best performing multi-modal classifier to our single modality ones. We also compare ourselves to other existing prognostic models. The most commonly used ones are Pulmonary Embolism Severity Index and its simplified version, SPESI, PESI, and SPESI. As can be seen here, our model outperforms all other uni models and clinical prediction rules in all metrics. This is especially apparent when looking at the AUC score, which is significantly higher than all other competing models. Here are the same results just presented visually. Our multi-modal outperforms the imaging by almost 14%, the clinical model by over 9%, and the clinical rules by 17 and 18%. We compare the AUC scores of our different multi-modal classifiers. Our best model is the intermediate model, but we can see that almost all fusion models, except the first one, improve results compared to single modality ones. To conclude, to our knowledge, this is the first work that attempts to risk stratify PE rather than detecting the clot itself. The 3D imaging scans are fed into the model as a whole, with only minimal pre-processing and with no additional markings or even slice-level annotations, making this method exceptionally weakly supervised. Our model can be used as an alternative prognostic score, achieving competitive results. Moreover, our data is not specifically collected for this research. This means that we can get these models' prediction results for free without any extra effort. The data was collected in a noisy and variant environment, making this a real-life solution. We hope to show success in real clinical practice. Thank you.